So today we're fortunate to have with us Professor Brian Lipworth from the University of Dundee, and he is also the founder of the Scottish Centre for Respiratory Research. Dr. Lipworth, welcome.
Thanks very much, Alan.
Can you first provide a few more details regarding your background?
So I'm a clinical pulmonologist with an interest in airway, allergy and physiology and pharmacology. I've been a practicing pulmonologist for, I guess, about 30 years, and I run clinics in airways disease, particularly in asthma, severe asthma, and also I run a rhinology clinic as well with my ENT colleagues.
Thank you for that. You're one of the authors of the ATS, American Thoracic Society, clinical guideline on the use of fractional exhaled nitric oxide, or FeNO, to guide the treatment of asthma. That was published in November 2021. Can you tell us about the recommendations made in that document?
Well, it was a single question guideline, so the brief was actually pretty limited, and it was looking at the utility of FeNO, fractional exhaled nitric oxide, to guide treatment in asthma. And it was basically a systematic analysis looking at all of the available literature, which was graded by the panel, and then on the basis of that some cogent recommendations were deduced.
Now, to back up for just a moment, the recent ATS guideline doesn't cover diagnosis. Do you feel that there's a role for FeNO in the diagnosis of asthma?
So if we're starting off with diagnosis before we come to treatment, then the answer is unequivocally yes, there is. And of course, you may have seen the EPR guideline as well on the use of FeNO in asthma. In fact, I wrote an editorial on that in the Journal of Allergy and Clinical Immunology last year. So yeah, there is definitely a role for it. For example, if you look at the NICE guidelines, the UK NICE guidelines, then FeNO takes a prominent role there. So after performing spirometry, looking for airway obstruction, looking for reversibility, then right up at the top of the algorithm, FeNO's right there in terms of a FeNO level more than 40 parts per billion in steroid naive adult asthmatics. And then the algorithm goes down and also looks at diurnal measurements of peak flow, and then airway hyperresponsiveness using bronchial challenge. I know certainly in my practice, everybody that walks through the door, as well as getting an asthma control questionnaire, an ACQ, while they're in the waiting room, they all get measurement of spirometry, FeNO, and in my clinic we also look at small airways function using airway oscillometry. I would actually feel quite naked, if you like, clinically naked, not physically naked. That'd be an unpleasant sight, but I would feel clinically naked if I didn't have the FeNO measurement when I'm assessing my patients for the diagnosis of asthma and also for the treatment asthma. It's something which is now completely integrated into our clinical pathway and is done as a matter of routine at every single visit, not just at the initial visit for assessment, but at serial follow-up visits as well.
Great. Along the lines of treatment and management, where can FeNO testing be useful in the management of patients with asthma? And let's start with the mild to moderate, since severe is a bit of a different thing.
In terms of treatment?
Yes.
Well, in steroid naive patients, the NICE guidelines suggest a FeNO of more than 40 parts per billion. The ATS guidelines suggest a FeNO of 50 parts per billion. I mean, at the end of the day, it's a bit of an arbitrary number. But a FeNO on its own, that will tell you whether the patient, a raised FeNO will tell you whether the patient is likely to have type 2 inflammation, Th2 inflammation, which responds to inhaled corticosteroids. And FeNO is exquisitely sensitive to inhaled corticosteroids in asthmatic patients with type 2 inflammation. And we've actually published data in the chest, which was cheesily called the FeNO trial, which you can look up. William Madison was the first author, showing that in such patients with a raised FeNO, these were steroid naive patients, that the FeNO drops by about 50% within the first 48 to 72 hours. And interestingly, in that study, there was a clinically relevant improvement in the asthma control questionnaire score, which exceeded the minimal clinical important difference of 0.5, which accompanied the reduction in FeNO. So on its own, it will give you a very strong indication of the likelihood that the patient's got type 2 inflammation, which will respond to inhaled corticosteroid therapy. In terms of predicting exacerbations, then you have to take into account not just the FeNO, but the blood eosinophil count as well, what I call the type 2 pivot, which is the balance between FeNO and eosinophils together, which is very highly predictive of exacerbations, together with airway caliber measured with spirometry or oscillometry, and of course asthma control measured with the asthma control questionnaire. So you have to take all of those together. But in terms of predicting an inhaled corticosteroid response, then FeNO and blood eosinophils are equally predictive. I mean, the beauty, of course, about FeNO is that, as you know, it's a point of care test. You get it right at the point of care when the patient's sitting with you in the room, so you can make a very accurate prediction, whereas you usually have to wait for the eosinophils to come back, then the patient's already gone and left, and you have to then communicate that to the patient either directly or via primary care. So in that regard, it's really the only point of care test for assessing type 2 inflammation in predicting a treatment response. So that's mild to moderate asthma.
And so where do you see FeNO being used in the patient with severe asthma?
In severe asthma, in that case, then as I've already alluded to, the combination of blood eosinophils, so an eosinophil count more than 300 cells per microliter, along with an FeNO more than 50 parts per billion in a patient with severe asthma who's got GINA on GINA step 5 therapy, is very highly predictive of whether they are going to get frequent severe exacerbations over the subsequent calendar year. In that regard, FeNO and eosinophils will give you a very accurate prediction of whether the patient responds to certain biologics. FeNO will not give you a good readout in terms of predicting whether patients will respond to eosinophil suppressing treatment, for example, with anti-IL-5 therapy like mepolizumab or benralizumab, but it will give you a very strong prediction of response to anti-IL-4 alpha therapy, or indeed anti-TSLP therapy. So we're talking here about anti-IL-4 alpha with dupilumab or anti-TSLP therapy with tezepelumab. Then FeNO is a very strong predictor of response in terms of reducing exacerbations, and also with both of those drugs in terms of improving airway caliber as FEV1. But it won't tell you about response to IL-5, where in that case it's purely eosinophils. And the reason for that is that eosinophils are predominantly driven by interleukin 5, whereas FeNO is exclusively driven by IL-13. So any biologic which has an effect on the downstream IL-13 pathway, so either an IL-4 alpha blocker like dupilumab, or an upstream alarmin blocker like tezepelumab, will have an effect on FeNO. They'll suppress FeNO, so you can actually monitor whether the patient's actually taking the drug, which is quite useful. And at the same time, the level of FeNO will give you a good readout in terms of predicting the likelihood of getting a meaningful reduction in exacerbation. So I couldn't manage my severe asthma patients without having FeNO measurements at initial assessment and also at subsequent serial assessments in the clinic, because obviously we follow our biologic patients very closely indeed.
Now, speaking of the test, in terms of the practicalities, how easy is it to do a FeNO test and incorporate it into your clinical practice?
It's a bit like falling off a wall, really. It's very easy. It's certainly a lot easier to do than spirometry, but perhaps slightly more difficult to do than with oscillometry, which is just done with normal tidal breathing. But it's a very simple test. I'm just thinking, I can't actually remember a patient with mild, moderate to severe asthma that couldn't actually do a FeNO test. It's very easy to do. It just takes a couple of minutes to do. And as I said, the crucial thing here is it's the only available point of care test to measure type 2 inflammation that we have available for us in the clinic. So it's something that's done routinely in all our patients, whether they've got mild, moderate or severe asthma. I think that's something really important to emphasize, along with, as I said, spirometry, oscillometry and asthma control questionnaire.
And so why do you use NIOX in particular in your practice?
Well, I've been using FeNO for about 20 years now. We started off with the gold standard machine, which at that time was the NIOX. It was actually the big brother NIOX, which isn't available now. And now, of course, it's like phones. They started off as big bricks and they've gone smaller and smaller and smaller. And the same things happen now with the latest NIOX VERO. So it was the gold standard then. As far as I'm concerned, it's still the gold standard now. So I have no intention of changing. We have dabbled with other devices, but in the end, we've always come back to the NIOX VERO. So, for example, we dabbled for a time, not in our research lab, but in the NHS lab, where we dabbled with the Bedfont No Breath, but we found the problem with that is that it markedly underread the FeNO, so we were getting a lot of false negative tests in our patients, and that's why we've gone back to use the NIOX VERO. It's very easy to use, it's very user-friendly. We know exactly where we are with it in terms of looking at historical values on our patients because of the long history of experience, and it's also crucially a very patient-friendly device as well. And also we've found over the years, which is why we've stuck with it, that the backup that we've got from Circassia over the years has been absolutely exemplary. Excellent.
Thank you for that. Do you have any other general comments about FeNO testing in the management of patients with asthma?
No, I think that really covers it. As I said, I think without measuring FeNO in my patients with asthma, I would feel, it would make things very difficult for me now to do. So just measuring spirometry alone would really make it so that it'd be like having one arm tied behind my back actually when managing my patients. So that's why we now feel it's an absolute necessity to do it in all of our patients who come for asthma, and it allows us to optimize treatment to get the best clinical outcomes, to get the best quality of life for our patients, and reduce the exacerbation burden. So it's really a win-win-win for our patients with asthma.
Well, we appreciate you sharing your insights, Dr. Lipworth. Thank you so much.
Thank you. My pleasure.